person can experience a complete psychological collapse without ever suffering a physical injury or facing an obvious traumatic event. For decades, the bedrock of crisis intervention relied on the work of theorists like Gerald Kaplan and Eric Lindemann. Their classical model operated on the assumption that a true mental health crisis required either a severe, acute precipitating event or a pre-existing psychiatric condition to trigger it. Clinicians eventually encountered patients presenting with acute distress who lacked any obvious external cause or prior mental health history, indicating that the classical definition was no longer sufficient. Relying exclusively on trauma-based models creates a diagnostic gap for practitioners, treating patients whose distress does not stem from a single external source. In 1985, Lawrence Brammer published The Helping Relationship, introducing a framework that expanded the study of applied crisis. Brammer identified that severe crises can develop organically in individuals who do not have a pre-existing pathology or history of acute physical trauma. This taxonomy categorizes psychological emergencies into 3 distinct domains: developmental, situational, and existential. Each domain operates on a different trigger, specific internal mechanism, and distinct clinical risk profile. Practitioners use these 3 categories to distinguish between the various mechanical roots of a patient's distress. The first classification is the developmental crisis, which identifies distress born from predictable lifespan progression. The trigger here is an expected normal life event, like a pregnancy or a college graduation. A milestone that is generally viewed as positive or normative can still cause intense systemic stress and strain on an individual. This timeline illustrates the underlying mechanism. All major life changes involve a loss of the previous state, which then requires a period of grief work to process. Even when a person progresses as expected, they must shed a previous identity. This shedding generates a sense of psychological loss, pushing their stress capacity into the red. To navigate this transition, an individual requires time to actively engage in this grief work until their psychological capacity stabilizes. In this domain, the clinician's role is centered on close, ongoing monitoring rather than acute trauma intervention. The therapeutic goal is to ensure the client safely navigates the transition and returns to their normal level of functioning. Developmental crises show that severe systemic distress can be a normal byproduct of human maturation rather than an indicator of mental illness. The second domain is the situational crisis, which aligns with the public understanding of an emergency. This spike represents a trigger that is entirely sudden and profoundly overwhelming. Unlike the developmental timeline, there is no predictability or normative progression in this domain. Specific triggers for this classification include motor vehicle accidents, instances of sudden loss, or sexual assault. The underlying mechanism of a situational crisis is the immediate failure of the individual's normal coping mechanisms. The extreme suddenness of the event leaves the patient with no time for the gradual grief work seen in developmental transitions. This is the domain that is most frequently encountered in the field by hotline workers, emergency medical responders, and social workers. Standard emergency response protocols are specifically designed to treat this type of acute psychological breach. Applying these acute triage techniques to developmental or existential problems will fail because the underlying mechanism of distress is different. The final domain of Brammer's taxonomy is the existential crisis. The core trigger is an internal evaluation of a person's life purpose and their level of personal fulfillment. This crisis involves the concept of actualization, the metric by which individuals evaluate their own growth and attainment of goals. This graph illustrates the mechanical cause, the realization that one will not reach the specific goals they had set for themselves at a certain age. The resulting emotion is often intense regret, or the belief that life has permanently passed them by. High-risk periods for this crisis occur at major life transition points, specifically at ages 30, 40, and 50. These specific decades force individuals to take stock of their trajectory and confront their actualization gap. A profound existential crisis carries a very severe clinical risk, ultimately shifting the patient's focus from internal reflection to mortality. There is an explicit link between this level of existential regret and a predisposition to suicide. Demographic data connects this crisis domain to markedly high suicide rates in both men and women. The literature specifies that the high-risk demographic bracket consists of individuals between the ages of 45 and 54. Existential crises demonstrate that a crisis of purpose can be as impactful as a physical trauma. This matrix shows the complete diagnostic picture, placing all three mechanisms side by side. Brammer's work demonstrated that psychological collapse is not exclusively triggered by sudden physical trauma or prior illness. Domain 1 accounts for the systemic strain caused by normal life transitions requiring grief work. Domain 2 addresses the acute breaching of coping mechanisms caused by sudden external events. And Domain 3 identifies the internal realization of unmet life goals and a lack of actualization. When faced with an overwhelmed patient, a clinician's first task is categorization. An effective therapeutic plan can only be formulated once the precise domain of the crisis is correctly identified. Mastering Brammer's taxonomy equips practitioners to see past symptoms of distress and target the mechanical root of the crisis.